So my name is Amanda Torbett. I'm a cardiology pharmacist here at Erlanger, and today I'm going to talk to you about lipid management in 2019, jokingly titled, How Low Can You Go? So today we are going to identify problems that are associated with hyperlipidemia, to evaluate historic treatment guidelines regarding the treatment of hyperlipidemia, distinguish the mechanism by which PCSK9 inhibitors affect cholesterol, and analyze potential concerns with very low LDL. So hyperlipidemia is considered to be a disorder of lipoprotein metabolism that results in the following abnormalities: high total cholesterol, high LDL cholesterol, also known as bad cholesterol, high non-HDL cholesterol, high triglycerides, and low HDL cholesterol. Approximately 1 in 3 adults in the United States fall into at least one of these criteria. So what are the common symptoms of hyperlipidemia? We'll go ahead and get you involved nice and early today. So our options are fatigue, dizziness, chest pain, or no symptoms. D, no symptoms. You are correct. Why is this not going to work? No symptoms. Perfect. Oh, we got it in 2 colors apparently. Advanced. Okay. So why do we care about hyperlipidemia? Well, there are 4 main reasons that we care about this. The first is atherosclerosis. So hyperlipidemia is the most important risk factor for development of atherosclerosis, which is the major cause of cardiovascular disease. It is characterized by accumulation of lipids, cholesterol, and calcium, and the development of fibrous plaques within the walls of large and medium caliber arteries. As a result of that, coronary artery disease occurs when atherosclerotic plaques within the walls of the artery cause narrowings within those arteries, and that the supply of blood flow is therefore limited to the myocardium, which results in insufficient oxygen supply to meet the demand. Acute MIs, or acute myocardial infarctions, are one manifestation of coronary artery disease, when blood and oxygen supplies are partially or completely blocked from flowing in one or more of the cardiac arteries, causing damage or death to heart cells. And then the final reason that we care about hyperlipidemia has to do with ischemic stroke. So ischemic stroke is one of the leading causes of morbidity and mortality nationwide, and ischemic strokes occur when an artery is blocked by a blood clot or piece of atherosclerotic plaque that breaks loose in a small vessel within the brain. Lower LDL and total cholesterol levels are associated with a reduced risk of stroke. So to better understand how we now approach treatment to hyperlipidemia, we have to first know where these treatment guidelines have come from and how these treatments have evolved over time. So I'm going to first start with ATP1, which was produced in production in 1988. And ATP1 focused on the treatment of LDL cholesterol with preference in medication selection given to niacin and bile acid resins. One major difference from ATP1 to our current therapy is that statins were not considered to be first-line therapy at this point in time. So when I think about how far we've come, and I start thinking back in 1988, they used niacin and bile acid resins as their first-line therapy for lipid management, it kind of blows my mind because those have been out of favor in newer cardiac management for quite a while now. So it's interesting to know where we started. The next column you'll see is ATP2, which came out in 1993. This utilized risk assessment to guide therapy, and the primary target for drug therapy became a reduced LDL goal of less than 100 milligrams per deciliter in patients who had coronary heart disease. This guideline included statins in the recommended therapy along with fibrates for mixed hyperlipidemia. So 1993 is really where you started seeing statins come onto the market and to start establishing their place in lipid management. ATP3 is the next iteration, which came out in 2002, and this lowered the LDL cholesterol level for therapy initiation in high-risk patients with an LDL goal of less than 100 milligrams per deciliter if you had a coronary heart disease risk equivalent. This guideline also identified that non-HDL cholesterol and metabolic syndrome were secondary targets of cholesterol therapy management. And then finally, HEP3 received an update in 2004. There was not enough new evidence and new studies out to produce an entirely new guideline, but they did produce an update which lowered the LDL threshold even more in patients who were identified as very high risk for coronary heart disease. It identified an optimal LDL goal of less than 70 milligrams per deciliter for patients who had cardiovascular disease or multiple or severe risk factors for heart disease. So essentially, treatment strategies have evolved from low to moderate dose monotherapy. When we first started utilizing statins, we gave patients low starting doses to see if they tolerated it, to see what the effect was on their LDL, and then if they tolerated it, we would double their dose. Well, anytime that you double a dose of a statin, so let's say you start with atorvastatin 10 milligrams, you get a baseline lipid lowering. And then when you double that dose, so you go from 10 to 20 milligrams, you really only get an additional 6% lowering in LDL cholesterol. And what we have found is that over time, is that patients actually do better and have more significant advantages within their cardiovascular profile when we initiate high-dose statins at first, really target that LDL lowering right off the bat, and then back down if we have to as far as dosing goes. So you'll see how our treatments have gone from low to moderate dose monotherapy to moderate to high-dose therapy, and now to high-dose statin therapy plus or minus combination therapy with additional agents if needed. So on the next several slides, I'm showing you what we talk about when we talk about statin intensity. So there are all these things and all these guidelines, all these papers out now that say if patients have cardiovascular disease, if they've experienced a stroke, then they need to be on what we call a high intensity or a high potency statin. So in order to be classified as a high intensity statin, the dose has to be able to lower your LDL cholesterol by more than 50%. So examples of statins that qualify for this are rosuvastatin 20 milligrams and 40 milligrams, atorvastatin 40 milligrams or 80 milligrams, and simvastatin 80 milligrams. For your viewing pleasure, I have underlined the formulary agents that we utilize here at Erlanger. You'll notice the asterisks on the simvastatin. This is because simvastatin in the I'd say 2010 to 2012 era, there was a warning issued about simvastatin 80 milligrams saying that if patients had not been over it for more than a year and tolerating it, that no one should be initiated on simvastatin 80 due to risk of myopathies and rhabdomyolysis. So if simvastatin 80 is therefore not really a high intensity statin because we aren't utilizing it, but for completeness sake, I have included it on this slide. Moderate intensity statins obviously are a little more plentiful than our high intensity statins. Moderate intensity statins lower your LDL cholesterol by 30 to 50%. Again, for our facility, rosuvastatin 10 milligrams would fall in this category, as well as simvastatin 20 milligrams or 40 milligrams. And then finally, we have low intensity statins. So these statins lower your LDL cholesterol by less than 30%. So for our facility, rosuvastatin 5 milligrams or simvastatin 5 or 10 milligrams would qualify in those categories. So as you all know, drug therapy is not the be-all, end-all for helping patients and their lipid profiles, nor lowering their cardiovascular disease. So we should also be talking about therapeutic lifestyle changes with these patients. There are four main areas that we think about when we talk about therapeutic lifestyle changes. They are diet, exercise, weight loss, and stop smoking. All of these kind of tie in together, and really it needs to be, attacking any one of these is good, but attacking all of these at the same time is better. And so we really shouldn't initiate statin therapy or other lipid-lowering therapy without also having a conversation with our patients about therapeutic lifestyle changes. So the first is diet. So diets that lower cholesterol are typically low in fat, particularly saturated fat, as well as cholesterol. So one of the best things you can do is to decrease the number of saturated fats that patients are eating. Regular exercise also affects cholesterol levels as well as your overall health. So people with active lifestyles have a lower risk of developing coronary artery disease than people who have sedentary lifestyles do. By the nature of what we as pharmacists do, we can be pretty sedentary at times. I don't think standing in place counts either, unfortunately for me. So one of the things that we have to focus on not only as healthcare providers but also as human beings is working on being more physically active throughout our days. There's lots of data out that you don't have to do 30 minutes of exercise at one point in time. Even a couple of minutes here and there that gets your heart rate up can be just as effective. So taking the stairs when you have the option instead of taking the elevator up 2 floors, walking from our lovely parking lots into the building, all of those things get your heart rate up and are good for your lifestyle as far as coronary disease goes. Weight loss is the next thing we'll talk about. So excess weight tends to increase your LDL cholesterol, and losing just 5 to 10 pounds can actually lower your cholesterol, your triglycerides, as well as your blood pressure. Eating a diet low in saturated fat, getting more exercise, these are all things that are going to also contribute to a patient's ability to lose weight. And then finally, cigarette smoking. So cigarette smoking is the leading cause of preventable death worldwide. Smoking decreases your HDL cholesterol, which is your good cholesterol, and is also believed to change your LDL cholesterol particles or your bad cholesterol particles to a form that promotes buildup and deposits in the walls of your arteries, actually making you at a higher risk for development of heart disease by damaging the heart and the blood vessels associated with that. So, moving right along, we'll go down kind of a timeline. So I gave you what our lipid therapy had looked like in the late 20th century, is that right? 20th century and early 21st century, and now we'll get into more contemporary lipid management. So first we'll talk about the 2013 American College of Cardiology and the American Heart Association guideline on the treatment of blood cholesterol. So evidence for these guidelines came from randomized controlled trials of statins, and the expert panel that came up with these recommendations utilized those to develop the guidelines for reducing atherosclerotic cardiovascular disease, which I'll from now on refer to as ASCVD because it's much easier to say. What these guidelines showed were that lower cholesterol levels lower your risk of ASCVD. Guidelines don't provide a comprehensive approach to lipid management, so one of the complaints about these guidelines was that they really only focused on lowering your total and your LDL cholesterol and did not pay as much attention to triglycerides or HDL cholesterol. It mostly focuses on the utilization of statins as first-line therapy and tends to leave some of the additional agents by the wayside. The most notable thing that these guidelines did were that they identified statin benefit groups. So historically, you came in with a heart attack, or you came in with a stroke, or you came in and your lipid panel was high at your primary care doctor. That's when you would get started on a statin for cholesterol lowering. But we now know that there are specific groups of people and specific groups of patients who have a higher benefit from initiation of statins than the general population. So we're going to talk about these 4 benefit groups next. So the first statin benefit group discussed are patients who have ASCVD. Clinical ASCVD is defined as acute coronary syndromes, a history of myocardial infarction, stable or unstable angina, coronary or other arterial revascularization, stroke, transient ischemic attacks, or peripheral artery disease. So patients who have clinical ASCVD, if they're under the age of 75 years old, should receive a high-intensity statin. If patients are older than 75 years old and they are not a candidate for a high-intensity statin, they should be started on a moderate-intensity statin. The second statin benefit group are patients who have an LDL cholesterol over 190 milligrams per deciliter without a secondary cause contributing to that LDL. So we typically think of these patients as our familial hypercholesterolemia patients, and these patients should always receive a high-intensity statin. The third statin benefit group consists of diabetic patients between the ages of 40 and 75 who have an LDL between 70 and 189 milligrams per deciliter who do not have clinical ASCVD at this time. The patients who fall into this benefit group should receive a moderate intensity statin unless their calculated 10-year ASCVD risk is greater than or equal to 7.5%. We're going to discuss how to calculate that score very soon, so just keep that in the back of your brain while we go through the next couple of slides. These patients who have a risk over 7.5% should receive a high-intensity statin. So a 10-year ASCVD risk is defined as a non-fatal MI, coronary heart disease death, non-fatal or fatal stroke, and those are estimated by pooled cohort equations. And then the final statin benefit group looks pretty similar to this other grouping in that they are 40 to 75-year-old patients who do not have ASCVD. These patients also do not have diabetes, but they do have an LDL cholesterol between 70 and 189, and they have an estimated 10-year ASCVD risk of over 7.5%. So as promised, here is an example of what the ASCVD risk calculator looks like. This can be easily accessed on the internet or on the American College of Cardiology app on your phone. This risk calculator considers multiple factors in deriving what a patient's 10-year risk of having coronary heart disease is. So factors that are included are the patient's age, sex, race, systolic blood pressure, total cholesterol, LDL cholesterol, HDL cholesterol, history of diabetes, smoking status, and if the patient is currently on antihypertensive treatment, a statin, or an aspirin. There are some limitations that exist within this calculator. The calculator does not account for a family history of coronary heart disease, does not take triglycerides into account, waist circumference or BMI, nor does it take into account lifestyle or physical activity. So we have a patient case. So MT is a 63-year-old white male who is seeing his primary care physician for a routine visit. He has a past medical history of hyperlipidemia and obstructive sleep apnea, and currently takes simvastatin 40 milligrams daily and aspirin 81 milligrams daily at home. His vital signs are as follows. His heart rate is 68. Blood pressure is 132/84. His hemoglobin A1C drawn today was 6.3%. And his cholesterol panel showed a total cholesterol of 175, an LDL cholesterol of 99, an HDL cholesterol of 34, triglycerides of 104, and a non-HDL of 141. So, does he fall into a statin benefit group? Yes. Any votes for yes? Any votes for no? Any votes for you'd like more information? Any votes in general? Thank you, Chris. Oh, hi, thanks. Thanks for the vote. Okay, so I agree. There's not quite enough information given in that to provide you with all the information you need for that risk calculator. Now, looking at some of the basics of this patient, you can probably have a pretty good guess if you think they're going to end up on one or not, but you do need a little more information. So I have gone in and I have typed in his numbers into our 10-year ASCVD risk calculator. So he technically doesn't have diabetes, although he is a pre-diabetic at this point in time. He has never been a smoker, which I didn't tell you before. You do know that he's not currently on antihypertensives. He is on a statin and is on aspirin. So this calculates his 10-year ASCVD risk as 13.2%. So based on that, he falls into our fourth statin benefit group, that he is between 40 and 75 years old. He does not have diabetes, but he does have a ASCVD risk of over 7.5%. So we will move on. So now, does he fall into a statin benefit group? And we already talked about this. Yes, he does. Oh, I just spoiled this. I forgot this was in here. My bad. So, which benefit group does he fall into? D, thank you. I spoiled my own question. That happens sometimes. So, what treatment change would you recommend for his current therapy? Would you continue his simvastatin 40 milligrams? Would you increase him to 80 milligrams? Would you change him from simvastatin to atorvastatin 20 milligrams? Or would you change him from simvastatin to rosuvastatin 20 milligrams? D, good. So the reason that A is wrong is because simvastatin 40 milligrams technically doesn't qualify as a high-intensity statin. Answer B is incorrect because we do not put patients on simvastatin 80 milligrams anymore. And then changing him from simvastatin 40 milligrams to atorvastatin 20 milligrams also wouldn't put him into a high-intensity grouping. So the only correct answer here is D, changing to rosuvastatin 20 milligrams. All right, so we will continue along our timeline. So the next consideration for contemporary lipid management comes from the American Association of Clinical Endocrinologists, and it's the Comprehensive Diabetes Management Algorithm. So this is a large chart, which I'll try to orient you to. So in the first column, you're going to see risk category. This grouping divides you into extreme risk, very high risk, and then demonstrates your risk factors in the next column. So what are the risk factors in your 10-year risk score for developing ASCVD? And then on the far side, it's going to show you the treatment goals for LDL cholesterol, non-HDL cholesterol, and ApoB proteins. So what I'd like you to see here is that for our patients who are determined to be at extreme risk, so they have progressive ASCVD, in patients who have already achieved an LDL cholesterol goal below 70 milligrams per deciliter, they have established clinical cardiovascular disease, or they have a history of premature ASCVD, so that's younger than age 55 in men, 65 in women. They're considered to be your extreme risk patients. And you'll notice that the treatment goals for these patients are significantly lower than they are for patients who are deemed to be at very high risk or high risk. So for extreme risk patients, your LDL goal is actually less than 55, your non-HDL goal is less than 80, and your ApoB goal is less than 70. PCSK9 inhibitors should also be considered in patients who have clinical cardiovascular disease who are unable to reach their LDL targets with maximally tolerated statin therapy. I'm going to discuss PCSK9 inhibitors in a lot more detail very soon, but because it also belongs in this grouping, I wanted to mention it here. The next group that wanted to get in on lipid management and how we should go about this was the American Diabetes Association, who released their Standards of Medical Care in Diabetes in 2017. So what these standards broke down were their recommendations into both age and risk factor considerations, and then they specify what intensity of a statin they recommend. So you'll see on the first column, it has to do with age. So in our younger than 40-year-old patients, if they don't have any risk factors other than diabetes for ASCVD, then they don't recommend any statin. If they do have ASCVD risk factors, they recommend a moderate or high-intensity statin, and if they have clinical ASCVD, they recommend a high-intensity statin. In patients who are 40 to 75 years old without ASCVD risk factors, they recommend a moderate-intensity statin if they are a diabetic patient. If you have ASCVD risk factors or ASCVD, they recommend a high-intensity statin. And then if you present with acute coronary syndrome and your LDL is over 50, or you have a history of ASCVD but you can't tolerate a high-intensity statin, you should be on a moderate-intensity statin plus ezetimibe or Zetia, which bumps you up into the high-intensity grouping. And then on this slide, it's the same columns, but this is for patients over the age of 75. So if you have no risk factors for ASCVD other than diabetes and the fact that you're over 75, they recommend a moderate intensity statin. If you have ASCVD risk factors, you can select a moderate or a high intensity statin. If you have ASCVD, they recommend a high intensity statin. And then if you have ACS, if you have acute coronary syndrome and an LDL over 50 or a history of ASCVD and you can't tolerate statins, they recommend moderate plus ezetimibe. The National Lipid Association obviously also has opinions on this too, so they recommend, they have recommendations for patient-centered management of dyslipidemia. What these recommendations show are that they recognize that increased levels of cholesterol cause atherosclerosis, and that atherosclerosis is the underlying process behind most ASCVD events. Therefore, reducing cholesterol reduces ASCVD risk proportional to the extent that cholesterol is lowered. So the more you lower your cholesterol, the lower your risk is. The National Lipid Association also states that statins should be the primary approach for reducing ASCVD risk. Continuing on, we're next going to address the addition of PCSK9 inhibitors to contemporary lipid management. So the American College of Cardiology released an expert consensus decision pathway which provided guidance on when providers should consider adding PCSK9 inhibitors for further LDL reduction. So the first place they should consider it are in stable ASCVD patients with no comorbidities. In these patients, you can consider a PCSK9 inhibitor if they have achieved less than a 50% reduction in LDL, or if they have an LDL that remains over 100 milligrams per deciliter on maximally tolerated statin plus or minus ezetimibe. So what a maximally tolerated statin is patient-specific. So my maximally tolerated statin dose may not be the same as yours. It could be that at higher doses I have symptoms. It could be that I have muscle symptoms, things like that, elevations in AST or ALT, elevations in CPK. Or it could be that I have tried multiple statins and do not tolerate any of them. So in some patients, maximally tolerated statin may mean no statin at all, depending on the patient themselves. The second place that you can consider the addition of a PCSK9 inhibitor are in patients who have ASCVD, who have comorbidities and have achieved less than a 50% reduction in LDL, or who have an LDL that remains over 70 milligrams per deciliter on maximally tolerated statin therapy. The third grouping are in patients who have ASCVD and a baseline LDL over 190 milligrams per deciliter, who have less than a 50% reduction in LDL, or continue to have an LDL over 70 on maximally tolerated statins. And then the final grouping are in patients with familial hypercholesterolemia who have an LDL over 190, who achieve less than a 50% reduction, or who have an LDL that remains over 100 on maximally tolerated statins. So the National Lipid Association also gave us an update that included the PCSK9 inhibitors in 2017, and they state that PCSK9 inhibitors can be considered to further reduce LDL for patients with progressive atherosclerotic cardiovascular disease on maximally tolerated statin therapy plus or minus ezetimibe, with an on-treatment LDL that remains over 70 milligrams per deciliter, or a non-HDL that remains over 100 milligrams per deciliter. So that's not that. What on-treatment means is that they are physically receiving treatment or they can't receive it, not that this was their baseline lipid profile prior to initiation of treatment. So what are PCSK9 inhibitors? At this point, I've mentioned that term several times but have not had the chance to fully define it for you until now. So PCSK9 inhibitors are pro-protein convertase subtolysin kexin type 9 inhibitors. So you can see why PCSK9 is much easier to say than all of those words, especially with this accent. So PCSK9 binds to LDL receptors and increases the degradation of receptors, which results in an increase in LDL receptors available within the body. Therefore, inhibiting PCSK9 leaves more receptors in circulation, which in turn lowers LDL cholesterol. So I'm going to show you a picture of what this looks like. So PCSK9 inhibitors are fully humanized monoclonal antibodies that interfere with the binding of PCSK9 to the LDL receptors. This leads to a higher hepatic expression of the LDL receptor and therefore lower plasma LDL levels. These antibodies are specific for PCSK9 and don't bind to other members of the PCSK family. Available PCSK9 inhibitors bind free plasma PCSK9 and promote degradation of the enzyme. So essentially there's less free PCSK9 available in the plasma to bind the LDL receptor, which gives you a higher percentage of the receptor upcycling on the surface. And you can see that in this picture. When those LDL receptors upcycle onto the surface of the hepatocyte, they allow the liver to remove more LDL from the circulation, which lowers the plasma levels. There are currently 2 PCSK9 inhibitors on the market. The first is alirocumab or Praluent, and the second is evolocumab or Repatha. Both were approved by the FDA in 2015. I'll start with Praluent first. It is considered to be an adjunct therapy with diet plus maximally tolerated statin therapy with familial hypercholesterolemia or clinical ASCVD, which requires additional lowering of LDL. And then Repatha is indicated for reduction of risk of MI, stroke, and coronary revascularizations in patients with ASCVD as an adjunct to diet plus lipid-lowering agents for hyperlipidemia, and can also be used as an adjunct therapy for homozygous familial hypercholesterolemia. So we're going to talk quickly about some of the trials that got these drugs approval for utilization. So the first is the OSLER trial. And what the OSLER trial set out to determine was, is evolocumab safe and effective in the long term for patients? It was a multi-center, open-label, parallel group, randomized controlled trial with a sample size of 4,465 in both phase 2 and phase 3. It evaluated if it was safe and effective in long-term use and found that evolocumab was effective in decreasing LDL in patients who were treated with maximally tolerated statins. OSLER also demonstrated an adequate safety profile. It did show a slight increase in neurocognitive effects, but noted that it was not correlated with the degree of LDL lowering and that it was not statistically significant. And what the OSLER trial found was that the number needed to treat with evolocumab was 90. So 90 patients needed to receive this therapy for someone to, for the reduction to be seen. It evaluated 2 different dosing strategies. So the first is 420 milligrams once a month, and these injections are given subcutaneously. They come in pen form, similar to insulin pens, so they can be administered at home. And then the second was utilizing 140 milligrams every 2 weeks. ODYSSEY is the next trial, and it was a multi-center, double-blind, parallel group, randomized controlled trial with a sample size of 2,310 that evaluated if the addition of alirocumab to high-intensity statin reduced LDL in patients at high risk for cardiovascular events. And this study found that alirocumab provided an additional 62% reduction in LDL without a significant increase in adverse events. So if you have a patient on maximally tolerated statin, let's say they got a 30 to 40% reduction in their baseline LDL while on treatment, you can gain an additional 62% lowering with the addition of one of these agents. Those are numbers that we have never seen before in the amount of lowering that's available. And the ODYSSEY trial utilized the dosing strategy of 150 milligrams subcutaneously every 2 weeks. It did show in post-hoc analysis that 2% absolute risk reduction in major adverse cardiovascular events, also known as MACE, and that absolute risk reduction is pretty significant. The next trial we'll talk about is FOURIER. It was a multi-center randomized double-blind trial with a sample size of 24,000 patients that evaluated the addition of evolocumab in patients who had ASCVD and an LDL over 70 milligrams per deciliter despite moderate or high-intensity statin usage on the reduction of cardiovascular events. And what they found was that the use of evolocumab resulted in an absolute risk reduction of 1.5% for major cardiovascular events. FOURIER also showed that therapy was well tolerated without excess of new onset diabetes or neurocognitive effects despite a dramatic reduction in LDL. This utilized either every 2 weeks or every month dosing, and that was totally determined by patient preference if they wanted to stick themselves once a month or every other week. So this will give you another example of how these dosings occur. So alirocumab for hyperlipidemia can be dosed 75 milligrams subcutaneously every 2 weeks or 300 milligrams monthly. It can also be utilized as 150 milligrams every 2 weeks, and that is an up titration from 75 milligrams if you did not achieve your desired lowering. And then you'll see that evolocumab has more options for dosing therapy depending on what you're utilizing it for. So for homozygous familial hypercholesterolemia, use 420 milligrams once a month. You can also use that for hyperlipidemia, or you can use 140 milligrams every 2 weeks. And then if you're using evolocumab for prevention of cardiovascular events in patients who have established cardiovascular disease, you can use either dosing strategy. This slide shows the pharmacokinetics of these agents. Overall, they are remarkably similar agents as far as their bioavailability, their elimination, their time to peak, and their onset. So based on pharmacokinetic profile, there's not one that is more appealing than the other. Adverse events I have detailed here for each of the agents, along with the frequencies that are detailed in the package inserts. For alirocumab, injection site reactions are the most commonly reported, and you'll see that between 7 and 17%. With evolocumab, nasopharyngitis is the most common reported, and that happens in 6 to 11% of patients. But overall, you'll see that PCSK9 inhibitors appear to be very well tolerated in patients. Another nice thing is that they have very few drug interactions. There is only one drug that you 100% cannot use either of these agents with, and is belimumab, which is used for lupus. Okay, so if I've told you all these great things and that you can get a 60% reduction in your LDL and you get a 1.5% absolute risk reduction in major cardiovascular events, why aren't we using these in everybody? So there are 4 big reasons for this at the current time. The first is cost. So we live in a cost-focused world and a cost-centered world, and these agents are incredibly expensive. Each of these agents carry a yearly price tag between $12,000 and $14,000 per year. There is some new data out as far as early this year goes, showing kind of where the break-even point is on these agents as far as numbers of patients needed to use in order to lower the cost of healthcare. And they've shown that the break-even point cost-wise on these is really more about $8,000 for patients rather than $12,000 to $14,000. And so you are seeing a decrease in cost over time. They are stepping these back a little bit so that they can increase their utilization. The second is also related to cost, and that's insurance coverage and willingness to pay for these agents. So most insurers are currently requiring a litany of paperwork and prior authorizations for use of these agents, which provides a barrier to patients and to the healthcare providers because they are stuck in a mountain of paperwork all the time. They do have high rates of initial denial, so the first time you ask for it, the rates of denial is significantly higher. That is improving if you can back up your documentation saying this patient has tried 4 statins and doesn't tolerate them, or they're taking their maximally tolerated dose and they've had 2 more cardiovascular events while on this therapy. We are getting some of them approved, but they are fewer and far between. The lack of long-term data is also a barrier to use because clinical outcomes data for long-term effects have not been fully recognized at this point in time. Side effect data is also going to continue to evolve as these agents are used more and more. And then finally, the other barrier to use is that it is a parenteral agent, and some patients are going to be resistant to having to inject themselves on a biweekly or a monthly basis. So the question that always comes up to me when we're talking about utilizing one of these drugs in my cardiology patients is, well, how low of an LDL cholesterol is too low? So historically, you've seen that LDLs were originally targeted to be below 100, and then it was below 70, and then it's below 55 in certain patients. So how low is too low? Anybody got a guess? This is not a formal poll question, just anybody got a guess? Okay, I would agree. That's probably too low. That's great. This is still a contested point in data and literature that's available. What we do know is that when infants are born, they have an LDL cholesterol of approximately 30 milligrams per deciliter at birth. This number goes up if patients are, if babies are breastfed, but at birth they have a LDL of 30, and they have gone through all of the stages of development with cholesterols in that range. So we feel very comfortable saying that patients can have LDLs in the 30s without any problems. One of the trials, the OSLER trial that looked at alirocumab, titrated or changed doses to maintain an LDL goal above 15 milligrams per deciliter, although patients who had LDLs at or around 15 milligrams per deciliter did not show any additional adverse effects compared to patients who were in the 30s. There are some potentially adverse effects that go along with very low LDL cholesterol. Some of these include cognitive or memory effects, steroid hormone and bile acid production. There's a risk of cancer, of depression, and for infectious diseases. But to be honest, most of these things can be attributed to other phenomena in most of these patients anyway. So the truth is we really don't know how low too low is, but we are very comfortable saying that anywhere around 30 is totally fine. Another common question I get is, well, this patient is now getting a PCSK9 inhibitor. Do they need to maintain their statin therapy? The answer is yes. So the trials that looked at these drugs had patients maintained on statins in addition to utilization with PCSK9s. So statins themselves have pleiotropic effects. They decrease inflammation in the body. They promote stabilization of coronary plaques. So they do other things besides just lower your cholesterol. So the current knowledge says that we should continue both at the same time. Anybody have any questions?